So Miriam, I have a big toolbox. I have the functional orthodontist. I have board certified sleep physicians. I have neurologists. I have acupuncturists. I have chiropractors. I have robotic trained physical therapists that think they can fix everything. But I have all these doctors that I can refer to get opinions on and say, would you look at this for me?
That's the key to your success. That multidisciplinary approach, I think, is what's unfortunately missing in our system, in our medical system. But that's the key to your success. And how can we make that better? How can we make that connection and communication with other specialists better? It's been really hard for me too. As a dentist, past 20 years, I've been trying to bring these different specialists under the same roof to communicate with each other.
It is a problem. We did come up finally. We came up with a pamphlet with my logo on it for sleep, MoreSMILES Sleep, and we brought it to neurologists at a huge concern called Ochsner here in the Gulf Coast. And I went to all the sleep physicians who were willing to listen to me, and I brought them calipers. I brought them how to use calipers. I brought them how to do a differential diagnosis, and I would give them lunch and learns. Well, the biggest compliment. Now remember, it's only one. You and I have friends that do 1 or 2 cases a day. I do 1 case. Right now I've got 3 cases going on, I think. And the biggest success of that is a neurologist and a sleep physician of 2 different hospital groups, but ones that work together right now, sent me a woman who was in a roller derby of all things. She was a roller derby a skater, if you know what that is. I never even knew that was still around. And so a neurologist and a sleep physician both sent me the patient. So I had to sit there and go, where do I start? Well, the fact that I always incorporate sleep and TMD into each other, I decided to go ahead and start with sleep, because there's a 70% correlation. Some people say 80, depends on which study you want to read, between myofascial pain and sleep. And her joints sound worse than my knees. They have so much joint mice in there that I didn't even take an MRI. We'd have to send her for new joints. But she had no pain and palpation. None. I palpated, medially, laterally. I pushed around everything I could, but all the pain was in the left cervical group and both masseters, and occasionally the right anterior temporalis muscle. So one of my mentors used to say, "Tens take a bite." Well, that's easy to say, but I got to think. So what did I do? I went, you know what? Let's do some studies. And sure enough, I was able to incorporate some more muscle groups, get rid of some fatigue, and I said, I can't promise anything, but we're going to try. So her jaw was getting kind of tired and everything else, so I said, let's just get you come back. So I tensed her again, shot a scan at 4 or 5, and one of my new dental assistants, heavily trained in Germany, was just stunned to watch the pistons go down as I moved her position, and she gasped, and the patient was like, what, with $30,000 worth of equipment on her head, and said, your jaw, in her German accent, your muscles are relaxing. She goes, I feel less pain now again, like I did last visit. And I said, don't move your head. So I aligned her again, and then
don't mess up my alignment. Yes.
And then I was so excited with myself.
Sensitive. Yeah.
I was so excited with myself. I gave her the first myobite that I took. I gave it to her.
I do that too sometimes.
To use, and then I took the other one, got ready to package up for you, and when I was filling out the forms, they realized I didn't take my 3 measurements.
Oh, you want us to do the Myoaligner for her? Perfect.
God,
it's okay. We'll measure.
No, she's coming back. Fortunately, she only lives 20 minutes away, not 2 hours or so.
Oh,
so, God, God allows me the opportunity to be humbled a great deal. So anyway, but that's my story, and I'm sticking to it. And if anybody is listening to this has not taken the red pill, you got to do it. Now, at 65 years old, 40 years in practice, maybe I'll be practicing another 15 years. I'm not sure there's going to be an ROI for me to get into some of the other cool things that I'm really seeing. So I'm sticking to the basics and trying to build on a foundation that I have without diving into things. But you don't know what you don't know. So I go to courses. I may not sign up for something. I may do something. I may refer a patient, but I'm always trying to learn what else can be done, what else should be done, and you see what you know. So I see little kids now. I've come full swing from not worrying about tonsils to every kid that has an ADHD diagnosis has to get a sleep test, to wanting every type 4 tonsil taken out, to being aware of the CHAT study, which said 50% of the time they get better, 50% of the time they don't. So all my ENTs breathed a sigh of relief that I wasn't going to be threatening to burn down their homes if they didn't do a surgery for me that I wanted. So now I'm a little more sophisticated. I'm a little more mature in my thinking. And, probably the smartest I ever was when I graduated from high school. The wisest I ever was will be tomorrow. I promise you. Because I learn something every day from a patient, from a video, from something on an internet group. But no matter how old you are, when I went to LBI in 2002, there was a 65-year-old orthodontist sitting next to me.
Mm-hmm. Nice.
And from Canada, and he was sitting there and he looked at me and went, "Is this blowing you away?" And I went, "Yes."
Mm-hmm.
It totally changed everything in his thinking. And he took the red pill just like I did. So I encourage people to minimally have this foundation set up, and you look at your patients totally different and differently, and it was just so helpful.
You don't
so
even need to look in their mouth.
What else do you want to know? Why tropical storm?
I just wanted to emphasize on the fact that you don't even need to look in the patient's mouth to see the problem. A lot of that, as you said, that ascending, descending issue, it shows as craniomandibular malalignment or craniosacral malalignment. And when there's malalignment, yes.
Yeah, just knowing to look at the thirds of the face.
Yes.
It's like, half the, not half, but often some of the TMJ patients that ENT send me, it's a denture with a bite off.
Yes.
Or it needs realigned.
Yes.
Or the vertical needs to be open and allowed to move the way it wants to. I don't always do a myobite on a denture. I will sometimes, a TENS bite, but I'll do a TENS bite on a denture. I'm getting ready to do a hybrid on a lower, and so after she wears the first appliance, after she heals, I'm going to be doing an orthotic, even though she's not in myofascial pain, to find the optimal bite. And many
we can make a nice full arch at Myoaligner. We can make a nice full arch to your implant abutments.
That's my intention. Because when I do a full mouth rehab on a patient that's overclosed, especially a class 2, I make them wear an orthotic, even if they're not in pain. If they're not in pain, at least a month. Now, I go to the 90-day, sometimes I go a year rule with an orthotic before I go to phase 2, because some patients will change things or they'll get hurt. But a lot of times, when I do a full mouth rehab, instead of doing a deprogrammer, I'll do a K7 myobite and hold them in that new vertical, in that new jaw position, and make sure they can tolerate that, and I'll build a case to that. So it's very useful, not just for pain, but just to see, where do I go from here?
Yes.
Rarely.
The diagnostic.
Rarely have I made an anterior ramp a thing. I've had a 16-year-old, she's now 21, who face planted, and her right condyle was totally moth-eaten. Brad Durham is friends with her parents, but they live here, and so he sent me the case, and so I had Dr. Brown take a look at it, and I said, after I get out of pain, can you stabilize her for me? He goes, sure, you do it your way, get out of pain, and he goes, we'll do the best we can. So she doesn't have a condyle up here anymore. It's just amazing. But Bill Dickerson had showed me he used to have a T-shirt that had no condyles on a panoramic and said, put this in CR, okay? But so we made her a nighttime appliance that she still wears to this day, just a suck down with a ramp. A buddy of mine in Arkansas taught me how to do this, and I went, hell, I was doing those in the 80s with Dr. Mohammed at L.S.U. And so I had that so her jaw wouldn't slip back at night.
Yeah.
I could have made her a sleep appliance, but I just made her that. And so now she's not in pain. She doesn't have to wear a daytime appliance because of the ortho. but she wears a nighttime appliance to stop her jaw from slipping down. And all these things I learned just from being around people. I tell people I always hang out with people smarter than me. That's why I'm so depressed all the time. So I just listen to people and I learn. I'm embarrassed that I'm sitting here talking to when I'm around.
You learned so much. I'm sure our listeners learned so much. And I agree with you that there's so many people suffering from it. And unfortunately, I don't want people like you to chase for a solution for 30, 40 years. There is, especially when there's such a high prevalence of people in modern societies that are suffering from sleep apnea and temporomandibular or craniomandibular disorders. But I think any dentist can learn how to take a TENS bite and at least put the patient back on physiologic rest position. You don't need fancy K7 instrumentation. You don't need a CT scan. You don't need sleep study. I mean, yes, let's have the sleep study. That's very important to have that done by the doctors, but at least get the people out of pain. And these orthotics are lasting long. I have a patient in Myoaligner for at least 3 years now. She lives in Hawaii.
Good.
And she hasn't, moved here to go through phase 2. She wants to do ortho. But our goal is to have 80% of dentists at least trained to to understand the difference between a splint and an orthotic, first of all. There's a big difference. And to get a patient in an orthotic. And that just takes one appointment to take a good TENS bite and maybe a few follow-up adjustments to adjust that orthotic. And then my goal is once the dentist has the patient out of pain, have the prosthodontist or have the orthodontist take over phase 2. Now that they know patient's comfortable here, what do you think a prosthodontist is going to do? Say, no, this is not the good position for you. I'm going to shove that mandible back where it was. No, they're not going to do that. The patient's not going to let them do that.
Yes, right. That's the key. Because around here with L.S.U, in the shadow of L.S.U, that would actually happen. So I still have to do my own full mouth rehabs. I have to do that.
That's unfortunate. And that's why we made, because when you remove a full arch orthotic, you can lose the relationship very quickly. And I thought maybe the segmentation of the orthotic, not only it reduces the flexion of the mandible and makes the orthotic more functional and easier to chew with, but also can show the orthodontist or the prosthodontist where our goal is, where we want to go. They can remove one segment and see that intraocclusal space. And even the dentist that is not very good at maintaining the bite during full mouth reconstruction, that was the toughest part of our full mouth reconstruction case, relining that bite during the prep when the patient was declined, and maintaining that bite. Now with a segmented device, you can even just do one segment and then come back, and you can get away with like partial arch reconstruction instead of taking the patient to full mouth reconstruction. But ortho, my hope is that more orthodontists will jump on board and take over phase 2. They start expanding the palate and they'll start uprighting the lingualize the teeth and do their magic with the orthodontics to get patients to maintain these patients long term. You and I know how stable our neuromuscular cases are that we've been doing in the past 20, 30 years. They're stable, especially if they don't have sleep issues. Their restorations don't break. So that is our goal, to have more general dentists to start phase 1 and at least stabilize people in phase 1. It's better than nothing. It's better than surgery. It's better than taking pills or committing suicide. Right.
No, I mean, there is the psychosocial technique is, as far as I'm aware, I mean, we just lost Dean Grimion, who was a great Penke instructor, very noble, honorable man, but they basically do psychosocial. They do gabapentin, they do Xanax or Zoloft or whatever, and then a splint, and they just adjust it to the cows come home. And it's not so much CR anymore, but just trigger point injections, and hopefully it'll go away one day. I've seen TMJ problems go away.
Yes.
And then I've seen them last 20 plus years. Mm-hmm. So don't tell me with my witness that a patient needs to suffer that long. Yeah. And only recently there was one patient who's Dr. Finger, went to Dr. Finger's synagogue, that came from across the lake to see me for a second opinion. And he brought his MRIs that were done properly, and I think he was going to see Gary Wolford in Dallas for new joints. And basically all his pain was in his joints. It was just in his joints. And, but he said, I know you have a different approach. Dr. Finger says you do something differently than what the guys at L.S.U try to do for me. And finally, I found this doctor who's going to give me new joints. I think it's Gary Wolford. And I had to concur. I said, this is probably your best hope. I said, I don't know where they're going to put your bite, but I said, that is probably your best hope. And not having a relationship with the surgeon in Dallas, I just let it go. But basically, it's a rare situation that that surgery needs to be done.
Yes.
And you know, I have one patient that I consider a failure. She has a beautiful smile, but she still clenches and grinds a little bit, and so she wears a night guard, but she is very asymmetrical. She has a withered hand. She has some postural issues that she doesn't attend to, and I think that's really part of the problem there. But just out of frustration, after about 2 years of trying to get things back to where I wanted them to be, I just made her a night guard, and other than that, she's fine during the day, but at night she'll still grind and clench her teeth, and I think it's more somatic than head and neck. So, you know, it's you're going to have your issues where you're going to have your frustrations. You and I just discussed a case I'd never seen before where a patient kept rolling, and you helped me with that case, and I had to do something unusual. I without tending her, I just said, okay, so every time I tend you, and I showed him how you showed me the bite, which was very eye-opening to her. It validated everything I was telling her. I said, look how much open you are. Dr. Merriam sent me this. And she goes, oh, and then this is my bite, and then this is what I look like. I said, yes. So without tending her, I just added more to the right side so she wasn't trying to close during the day. And then I started tensing her from there. And now I think she's fine. But I was so frustrated, as I told you, I'd made her a whole 1980s suck down with orthoacrylic on it. And now I've got your Myoaligner with just some hybrid on it. And now I'm adjusting that. And so, you know, she's been in pain for so long. Every time she gets a new pain, instead of listening to me that it's a bump in the road, she's like, this isn't going to work either. And I go, wait, your pain over here is gone, and now you have pain over here. I told you that. And I said, it's just, everything is decompressing, everything is roll, pitching, yawing, moving forward and back, side to side. So I think, hopefully when I see her this week, of course it doesn't help that we have 2 storms coming through, but when I see her, we're okay. Some folks are not going to be okay, but we're going to be okay. I'll see her this day that it will help out. And
are you finding the compliance is better with these tooth-colored appliances? Are you finding people are wearing them more often than the traditional acrylic?
Yeah, yes. Right now I'm playing with the clear again. I may actually separate in the midline, like either you or somebody else told me to do. Yeah. So I'm playing with all this.
I learned that from Ira Shapiro. Yes.
Yes.
Yeah.
God bless him. So I'm playing with all these things, and you know, Clayton Chan told me that I overthink everything, and he's probably right. You know, yes. You know, I think I overthink everything. I have neuromuscular friends that probably couldn't even tell you the organs in a cell, but I think down to that level. And so it's like, if I could memorize all the inflammatory enzymes, I'd probably be putting that to a patient. But the idea is, when the case I sent you today, I started looking, is it going to snap in this way? Or we're going to have to do it that way? Or am I going to have to do it segmented? Or am I going to have to cement it in? So I wrote you a note saying, if you can't do it this way, do it this way.
Okay.
Because I worry about everything. And
looking at those cases, 3D is so helpful, though. You saw how I send you the 3D articulation, so you can, you know, yes. it just gives us a lot of you know, options. Yeah, our designers are working really hard to get these fitted just perfectly. I understand you had a really good luck with your bonded one too. You're LVI trained, so you used to fix orthotics. I did fix orthotics forever too. Right. But I hated the liability that came with it, you know, and, you know, it kind of like twisted everyone's arms into going into full mouth reconstruction. I didn't want that. And orthodontists had a really hard time working with it. So I'm hoping that with these, how was your experience with delivering a bondable Myoaligner?
Well, that was the case that she had a concussion, and
Oh,
I'd put the concussion off to the side because she had some swelling of her masseter muscle, which I'd seen before, and I hadn't helped her much. And finally, she went and had surgery done, and I lost track of the patient. I emailed her last year. This was years ago. And so when I saw this patient, I went, your masseter muscle is swollen. So I kind of ignored the concussion thing, but I got the swelling down with the fixed appliance. So she said, I think this is going to work. But I only brought us so far. And she kept having some headaches that were deeper than just muscular. And so a chiropractor here locally had a person in Pennsylvania who did cranial sacral manipulation, couldn't think of the word. And I had gone up to Prabhu's house a few years ago with Dan Jenkins and some other people, and listened to an Australian physical therapist that was doing it. I think with Anne Marie, maybe, I can't remember. But anyway, so I knew that was out there, and I knew it might work. So he did 4 treatments a day for 5 days, and she came back and she said, I felt better on your orthotic, but he made me take it out because he didn't know what that was going to do, and he wanted to see how far he could take it. And so she got out of pain. So I was like, okay, that's another tool in my toolbox now. I have to pay attention to that. So, but the experience with the fixed appliance with her was excellent. But was it the treatment that she needed? No. But then again, if you saw the list of how many people she had seen before she got to me, it's just that I didn't happen to be the last doctor standing in that case. There was one more after me. But the experience with the fixed orthotic made her life better.
Much better.
And the fact that it wasn't removable, she could speak better with it, and she appreciated that a great deal.
Did you like that better than making a fixed orthotic in the chair for her? Was that easier for you as a practitioner?
God, I hate doing that. And I am an impatient person, and the lab that I was using never really quite got it to my extremes that I wanted it without this much or that much. And then I'd almost survey the case so I knew how things would fit. And then my wife kept pushing me, well, so-and-so does this, so-and-so does that. And I went, well, so-and-so doesn't mind grinding with fine burrs on patients' interproximals on their tongue. So when you came up with your appliance, it was a godsend to me. So I like to be on the cutting edge, not the bleeding edge. So I hang out with other people that are a little more quick start than even I am. And I go, so how'd it go? Did the patient die? Was it okay? And so I'll let those fools do things. And I kind of go, okay, maybe I'll try. So that was the lay there. So I was always sniff around y'all's booze and kind of, talk trash to your people, and then and say, yeah, I'm gonna send y'all a case one day, and walk away with brochures and go, I gotta find somebody who's doing that. So usually I run to John Highsmith because he'll try anything, and then I'll look at other people, and then our Shapiro, I think he calls anything bullshit he doesn't like. So I sniff around him, and then I'd go to Prabhu, good old trusty Prabhu. Yeah. What you think? And he's like, well, I have my way of doing things. So I'm like, okay, you don't count. So let me go find somebody else. So and so finally I said, okay, I'm gonna do this. So so I've only done, I think, 4 maybe with you now, and so so I'm not a great testimony, but hopefully I'll get back on track with this next case, the roller derby queen. So we'll see what happens with her, but I think it's gonna be really good.
Well, we really appreciate your trust in us, and we look forward to years of collaboration with you and your patients. I really would love to see more scans, K7 scans. If you have all those documents, you want to send it over our way. A lot of doctors just send us the scans and ask me for the best design of the appliance. So that would help for me to know what your long-term plans are. Are you going to go into phase 2, not go into phase 2? That really helps me design, decide on the segmented, bondable or not.
Well, here's the deal. One advantage, this is not a sales pitch for your company, but I guess it is. You're a dentist, and you're a neuromuscular dentist, okay? So that's kind of a two-edged sword. Number one, you can help a doctor less experienced like I am with your appliance. But number two, there's a temptation to lean on you, which isn't a bad thing in the beginning, because essentially I'm accidentally doing that. I'm going, oh my God, I'm so frustrated. This doesn't come out right. I'm not sure what I like about this. But you being able to help me, okay, what's going on here? What did you see? What happened? That is enormous help. And I love my ceramic teams. I love, because I used to do my own gold work, but I don't do my own porcelain now. I have a life. So I love the people that used to make orthotics for me and all, but having a neuromuscular dentist being able to call me up and be able to discuss her technology and say, well, this is what I saw and this is what I found, such as in the case Amber, who's rotating, that was golden, because it validated what I thought I was going to try, and then it opened my eyes up that, well, then that will work, and then I can do this. So that was really a cool thing. It's a real advantage to your company. Once again, not a cheesy sales pitch.
Thank you. I'll keep us going, because it's not easy to be a dentist, and also to be on the clinical side of this lab, So, but my goal is for more and more dentists to learn this, eventually learn this, and at least learn phase one and be able to stabilize their patients and get the stories, get the success stories that you and I hear every day in our practice. That is.
And they have to be courageous.
Yes.
They're going to be denigrated. They're going to be shot down. I'm an evil witch doctor in the New Orleans area. There's one guy, Johnny Bear, a friend of mine, who's on what we call the West Bank, which is about 50 miles away from me. And then CJ is over there in Lafayette, and he's awesome from what I heard. And there's an LVI person over in Alexandria, Louisiana, in the middle of nowhere, that is doing a lot of sleep appliances. So I think you'd be surprised how many of us are really out there who are studying neuromuscular dentistry and who are doing it. But the peers around you, who especially the ones that are beaten up with CR, are going to think you're crazy. They're not going to understand. And you just have to just give them the good news and tell them, this is what have you thought about this? Have you felt this? And my testimony is golden. Nobody can refute the truth, because it's what I experienced.
Mm-hmm. That is so true. Well, I wanted to thank you for your time. I know how precious your time is. Your patients are probably waiting. And if you have any advice for younger dentists, or dentists that are not seeing what we're seeing in their patients, just please feel free. And we really appreciate your time.
Give them my number. Call me. Call me. I mean, I'll talk to you on the phone. We'll go out to dinner.
Especially if they're football fans, they'll definitely call you. Trying to get in.
Well, just remember. I mean, we did hockey players. The P3 company, when I worked with them, flew the #2 women's racquetball pro all the way from Phoenix, Arizona, to see me, because she wanted to be #1 again.
Yeah.
And it helped her. Now, I don't know if she ever made #1 again, but she said her game picked up. And it doesn't help every athlete, but that was a real further validation of neuromuscular dentistry for me. And that wasn't even follow-up. That was just one bite. On an appropriate patient. And they won the Super Bowl. I didn't get a ring medal.
Hockey team, wasn't it the hockey team in
Canada.
From Canada? Yeah.
Canada.
They won gold medal. Yeah.
Shaquille O'Neal, Terrell Owens, my friend Bryant did Forrest Bryant did some Titans. He's up in Huntsville, and he did some Tennessee Titans. They're all out. They're out there, And I don't know if Jose's ever done another player or not. Jose Bush did down in Miami. I don't know if anybody else has ever done one, but I'm still willing to do one. It was just a fabulous, amazing piece of equipment when used on the appropriate athlete. And but anyway.
And
anything else you want to talk about? The weather? What?
We can make phase one affordable for a lot of people. Phase one doesn't have to be fancy. It can just be a good tense bite and be affordable, and that way more people can access it. And ultimately, it's going to impact public health. because not so many people are going to suffer. And it's a great gateway into understanding that the bite is related to the airway, you know, and just so they can get even better, more help, you know, once they enter this gateway and they gain our trust that, oh yeah, we are helping them, you know. So that's very important. Well, thank you, Dr. Jim. It was an honor to have you. And
thank you.
Yes, we'll go ahead and post this and post your 5-page long resume along with this, so people can learn more about it.
No.
I thought my resume was impressive. I don't think that after interviewing a bunch of you guys.
So, as I said in high school football, I repeat, my reputation exceeds me. But it worked for me then. It kind of works for me now. But anyway, listen, I love you. I love your company.
Thank you.
I love Aaliyah. You're always very helpful.
She's amazing.
To this poor, simple dentist. And so anything else I can do, and you honor me by even asking me to do this.
Oh,
if it makes the cutting room floor and I never see it, that's fine. That's fine.